Hello, everybody, and welcome to our Pace College of Health Professions Dean's Roundtable. I want to let everybody know that this program is being recorded for future use. It's great to see all of our students, as well as a class of students and faculty and staff here in administration today. Thank you. I am pleased to be introducing our speaker, Rose Madden Baer. Dr. Madden Baer is the Senior Vice President of Population Health and Clinical Support Services at VNS Health, a position that includes oversight of the organization's care management organization, education and professional development, and the community-based in-home medical and palliative care practice. Prior to that, she held positions in clinical operations strategy and development and behavioral health. Before joining VNS Health in 2004, she worked at Metropolitan Jewish Health System as Vice President of Quality Management. Dr. Madden Baer is a consultant associate professor at Duke University and assistant clinical professor at Yale University, and served as chair of the National Advisory Board for Duke University's School of Nursing's Executive Leadership Doctor of Nursing Practice program. Dr. Madden Baer has a Bachelor of Science from Nursing in Long Island University. She holds several advanced degrees, including a Master of Science in Nursing from Hunter College, a Master's in Healthcare Administration from St. Joseph's College, and a Doctor of Nursing Practice from Duke University. She is board certified as an advanced practice nurse and received postgraduate certificates from Duke University in Population Care Coordination, in Population Health from Jefferson College of Population Health, and in Executive Leadership from Cornell University. We're honored to have somebody as accomplished as this for our Dean's Roundtable speaker today. She was also inducted as a fellow into the American Academy of Nursing and the Hartford Institute for Geriatric Nursing. She served on the CMS Technical Expert Panels for Population Health Measures, Multi-Sector Collaboration in 2016, and Home-Based Care Models in 2017, and for Home Infusion Payment Models in 2018. And she has served on care models governance committees under New York State's Delivery System Incentive Reform Incentive Payment Program, the DSRIP program. And very honored again. Thank you so much for taking the time. It's turn over to you.
Thank you very much, Dr. Tai, and I really appreciate and am honored to be speaking with you today a little about my what I call my journey and the journey and trajectory of my career, and how I started in one place and ended up somewhere else, and and just sort of the opportunities that were afforded to me in my career. I like to always start by saying, number one, I'm a child of immigrants. And both of my parents came from Ireland, and I am first generation high school. So, people talk about first generation college. In my family, I was first generation high school with my parents. I'm from Brooklyn. You'll probably be able to tell that from my accent. And I lived in a home in South Brooklyn with 4 adults and 9 children in one house. So I learned a lot, and I mostly learned how it helped me to be resilient and focused, and to really, understand like what it is I really wanted to do, with my life and with my career, and and what I needed in terms of, I'll talk a little about lifelong learning, because many of the degrees that we talked about is, frankly, my doctoral degree I got at the ripe old age of 50. So, so let me begin. So I started in nursing school, but I really started as a certified nurse's aide. I'm one of those individuals that sort of did everything, you know, in terms of opportunities, like in terms of jobs in healthcare, all the way up. So even though I was on a scholarship from Long Island University, I worked nights and weekends as a CNA. And I often say that's what helped me grounded. From there, I went into hospital nursing. I learned telemetry. I worked all different, I worked at different hospitals. I worked both urgent and emergent care. I worked at Sloan, and that a little about that is because my MSN is in advanced practice, but it's in advanced practice in oncology. I have always in my entire career been drawn to what I call the intersection between medical and behavioral, and I'll talk a little about that and how that has influenced my career. And so I worked in different hospitals, and then I decided to venture into what I call home and community-based services. After my hospital career, I went into, I was a full-time visiting nurse, so I visited patients in their homes. I often say social determinants of health is not new. We just didn't have a label back then for it, but many homes I walked into, they had no food in the house, or it was shelters and things like that. So I learned a lot about environment, the community, the different communities. I worked in all kinds of communities all over Brooklyn. And I was back in the day, what they affectionately called a walker. A walker meant that you basically went from one community to the other, taking buses or trains, or just walking, or just like sort of going from adjacent communities to from one adjacent community to another. From there, I started, I worked full-time as a visiting nurse, and then I was asked to start to look at the possibility of me being a clinical manager. I was just finishing my master's in oncology, and all of a sudden I got into, and for all of those that don't know, home care, healthcare is a business. It's the business of healthcare, and I was a clinician, and then I was asked to start to manage people, manage budgets, manage things like that. So I said, okay, well, I believed I had terrific clinical skills, but now I needed to really sort of broaden my experience and my education. And I went back to school and I got a master's in health administration. And in that, it basically was learning organizational theory, things like marketing, budgeting, labor relations, and all those things that are really extraordinarily important when, people management, and, workforce and employee relations and all those things that are important when you're also, when you're a manager. And so I was a patient service manager. I was a clinical manager. I was ultimately promoted to be a director of patient services. And in that capacity, I was overseeing a very large census of what I call patients and members, and a large staff, and both field clinicians and back office clinicians. And then, and that was at Metropolitan Jewish Health System. And then I became a vice president of quality management, because I was always very interested in quality and customer experience. And then they asked me if I would consider being the chief compliance officer, because that was just starting to begin to look at what compliance would look like, and codes of ethics in healthcare and things like that. I'm somebody that always embraces a challenge. I pride myself on creativity, learning new things. So that's always been important to me, lifelong learning. So I said, okay, I'll with very little, I have to say, with very little direction, but that's probably something that I'm comfortable with. I'm pretty self-directing, and I did compliance and quality management, and then I moved into VNS Health. At VNS Health, I started a medical practice. I worked in the certified home health agency. I continued to do what I call per diem high-tech home care services, which for those of you that don't know exactly what that is, I was giving chemotherapy at home. I was doing infusion, IV antibiotics, peripherals. I was doing pain management, all of that. But I was doing it in the home setting. I chose to do that because I felt like it made me a better leader, to remember what it was like to be out there and to keep me grounded, frankly. And so I came to VNS Health. I've been with VNS Health for 2024, it'll be 20 years. And in 20 years, I've probably had six or seven different positions. I'm the person that they often say in this organization, if nobody else wants it, give it to Rose. She will absolutely embrace it. And that is true. We embarked on several demonstration programs with the federal government. And so I would be like, if it's broke, give it to me. Or if it's something new and exciting and I feel like I can develop it and create it, I'm very much interested in that. So you heard about the care management organization, and I kid you not, when we embarked on creating a care management organization, there were myself and two others, and I'm a little bit old school, so you'll be able to tell my age. I had a pad and colored pencils, and I drew what they call these days a mind map. And a mind map, they have software for that, but in this mind map, I drew a vision of what I thought the medical practice and the care management organization can look like. And it was like sort of just envisioning like something out of basically nothing, and saying, if we were to do evidence-based care management, and what would that be? What would that look like? Plus, I had the the ability to be able to tie that to education and professional development, which also reported to me at the same time. So I was in a great place of being able to say, okay, I want to incorporate this. Let's add this to the training curriculum. I was able to do that. Well, fast forward. The care management organization is one of the largest organizations at VNS Health. We are about, in just the care management organization, this is not even counting the medical practice, there are over probably close to 200 individuals, and from this hall closet of 3 people. And I mean, we were in a hall closet and with the little tables and chairs. So I often say, don't be afraid. Many times I've heard people say to me, oh, you have to have systems and you have to have elaborate technology and you have to, and I said, well, yes, that comes, and that comes with, financial responsibility and being able to be large enough to start to support that. But I said, healthcare is a business, and we started on spreadsheets. We literally started on spreadsheets, and I actually thought it afforded us the ability to be able to tweak what we want, tweak and change I believe in rapid cycle PDSA, which is basically we see something happening, sort of doing, rapid quality improvement. Today, we have elaborate dashboards. I'm an absolute data geek. Absolutely. So I often say some of the successes of the program, of the programs and the divisions that, that I operate is my ability to understand, to look at data, analyze data, understand it, let it drive clinical decision support for me, and then be able to marry that to, the financials and the business of healthcare, and making sure, I'm sure people have heard this, no margin, no mission. We are a mission-driven organization. We always have been. We're 135 years old. Our organization is the organization that was jumping over the rooftops, in the tenements of the early 1900s. A lot of history. Our founder is the founder of public health nursing, but with all that, you have to be able to, be responsible, accountable, and to not only yourself, but to your patients, your members, your employees, and all of that. So that's where that took me. I was lucky enough so when I went back from my doctorate, I told you I believe in the integration of medical and behavioral. So when I did my MSN in oncology, my thesis was on the altered body image for colostomy patients that have cancer. So it was really about the sort of not only the medical components of having an oncology diagnosis, but then the altered body image and the depression that comes with that, and how does that affect health and well-being. So, and I was always interested in that. So that's what I did my master's thesis on. And then when I went back for my doctorate, I did it on the integration of medical and behavioral, but I looked at depression and anxiety in the homebound elderly, because they suffer from what I called extraordinary social isolation, especially when they lose a partner, or they lose, many of our patients have been, in relationships for 40 and 50 years. And I used to see a phenomenon where, a spouse would die, and then, within months, you would see this depression and this change in the other spouse. And not too long after that, that person became infirmed and, functionally, socially isolated and depressed and all of that. So I was always interested in that integration. And today, I'm very happy to say that everything we do, so our medical practice is primarily nurse practitioners, but we have palliative care physicians. Also, the phenomenon of what I call end of life carries extraordinary, not only medical consequences, but also extraordinarily psychological and psychosocial consequences as well. And so we have specific programs around palliative care and all of that. All in all, I think at the end of the day, I probably have about 10 different programs within the care management organization, and some of them are transitions of care programs. We have end-of-life programs, palliative care, longitude, complex chronic condition, models of care, and acute care, some acute care programming as well. I talked about loving creativity and challenge, And often my division is what I call the laboratory for innovation. So any new technology that gets presented to the organization is usually tested, much to the chagrin of my staff. They're like, okay, we're testing another technology, but we do pretty bold things in terms of technology. We're doing remote patient monitoring with peripherals, and that includes stethoscopes, pulse ox, blood pressure, weights, virtual technology, virtual telemedicine. We're doing innovative stuff around alert management technology. So for example, if somebody arrives at the ED, I get pinged, and right away we know that we have to sort of activate our assets to prevent that inpatient admission, because that's what it's really, we're trying to reduce the ED visits and all that entails. Nobody wants to sit in an ED for hours and hours. It's not a great experience. And, and often people can acquire nosocomial infections in EDs or in inpatient. And we really strive to, so we have ED diversion programs, NP triage, all of those things. And there's a lot of technology that we deploy, as an asset to that. I have technology that if I have a number of patients that are in Washington Heights that speak only Spanish and have food insecurity and need food pantries after hours, I have that kind of technology that I can, refer to that technology, use that technology to help with those social determinants of health. During emergency disasters, and we just had that terrible flooding in New York City, we deploy what's called interactive voice response technology, and we run campaigns. Do you have food in the house? Do you have somebody with you? Do you have medications? Do you need us to refill those medications? Do you need us to deliver food for you? And I'm, as Dr. Tai has said, I have spoken nationally. I've been lucky. I've been able to speak nationally and locally. I serve on a few boards, American Heart Association. I was inducted as a fellow into the American Academy of Nursing and some other associations. But I just had a really pretty cool thing happen to me recently. I just spoke at the UN General Assembly on, I was asked to speak on the care of seniors and care management and keeping people safely at home in front of 100 healthcare world leaders. So that was pretty cool. So that's me in a nutshell. I don't know if you had any particular questions of me, and that's a little about my trajectory. I just, as kind of a closing point, is if you asked me when I was 20 years old what I was going to be, I would say to you, I'm going to be a nurse, okay? And at 18, even at 14, I would have told you I'm going to be a nurse. My life has taken very different, different trajectories. At all times, I consider myself, I'm a clinician. My daughter would probably tell you I'm a businesswoman, and I think that my perspective on this is, I started off being able to impact individuals one-on-one, bedside nursing and one-on-one. And now I'd like to believe I'm impacting individuals, patients, members, the community at a population health level, and impacting those lives, numerous lives every single day. So that's kind of my closing comment. So any questions?
I actually have a question, if you don't mind.
Not at all.
A statement and a question, actually. Thank you so much. That was very informative and very interesting. I'm actually a junior in undergrad at PACE in the College of Health Professions. I'm on a little bit of a different path. I'm pre-optometry, but my major is health science with a focus in health policy and advocacy. And I'm kind of like very not lost right now, but I guess I have so many options with what I can do that I don't know exactly what to go into and what the right choices to make. So I just wanted to get like your opinion on, I guess, the stigma around how everyone's going to med school now, or dental school or optometry school, and everyone, wants to make these big salaries, but no one really goes into what they truly love. So I just want to see what you think about that. And, if someone gave you the opportunity at like age 18 to, I know you said you would still go into the same path and everything, but if someone, told you that it would take so many degrees and so many bumps in the road to get to where you are, would you still go on the same path that you did?
So you're talking to somebody that believes you need to be passionate about the work you do. I'm very pragmatic. You need to, salaries are important, benefits are important, and all of that. But at the end of the day, I believe that you need to be passionate about the work you're in and the work you do. For me, I say I'm very lucky because I have the gift of giving back. And I say that, I evacuated patients on 9/11 out of Battery Park City. I did Superstorm Sandy, I ran, we did pop-up clinics for individuals in the Rockaways and Howard Beach and, Snug Harbor and all of that. And I thought, and to me, I think that, the sort of what I call the material things are important. They're, they're important to have a good life and all of that. But, for me, I have to be passionate about what I'm doing and the road I'm taking. And I can tell you that passion has been the thing that has driven me from saying, okay, I've moved from bedside nursing and now I'm now moving on to something else, and now I'm moving on to something else, and it still has been that passion that's driven me. People say to me, do you think you ever wanted to go to med school? And I'm not somebody that ever wanted to go to med school, because it was the what I call the art and science of nursing that was always so important to me. The science, obviously, the evidence and the research, but the art was the caring part, like the ability to spend more time and not 7-minute or 20-minute increments, but spend time. And that's what drove me also to home and community-based services, because in home and community-based services, you get to see individuals in their lived experience, in their own lived experience, in their homes. I got to educate them. I got to meet their families. I got to see caregiver burden. Caregiver burden's a real, is a real thing. And I worked in an ED, and I used to say, okay, here comes the social drop-offs. And the social drop-offs were when poor caregivers were completely overwhelmed and they couldn't handle it anymore. And they would, take their their loved one to the emergency room. So I think it's both. I'm not somebody that was, that said, okay, should I do this? Should I go into this? Or should I just go to med school or whatever? To me, it was always about the passion. What is drawing, what draws you to this? And this might sound maybe sound a little goofy, but for me, it was like almost a calling. So, that's what drove me. And even with what I'm doing today, even though it's not bedside nursing, again, it's the impact on people's lives, and what I call the gift of giving. For me, the gift of giving back. Not everybody gets that. Not everybody, gets to say they get the gift, the ability to pay it forward, and the gift of giving back. And for me, that's what it was.
Thank you so much. Yeah,
Did that answer your question?
Yes, thank you. My ultimate goal is definitely to help people. And again, like, to me, the salary doesn't matter. I guess it's just a stigma right now. And, with social media and everything and everything around you, it's very influencing. And, but yeah, thank you. I'm, like I said, I'm a health policy and advocacy major. So I kind of have two paths that I'm deciding between right now. So we'll see where
don't diminish health policy, okay? Because I do a lot of health policy, and I often say, so if you heard Dr. Tai speak, I actually participate in technical expert panels and when I spoke at the UN General Assembly, the Department of Health and Human Services was there. I do testimony and all of that. That's impact. That's impact. That's impact on generations, future generations, current generations, and that's impact as well, just on a really large scale. So don't minimize that either. I think health policy is extraordinary.
Thank you so much. Yeah.
While we wait for some other questions, I got one in the chat. What is a piece of emerging technology that you are excited about?
AI. So let me explain a little how. Okay, so and I didn't talk when I mentioned technology. I didn't say that. I didn't actually call this out. So today, in all the models that I use in our care management, the clinicians, with the clinicians, so I talked about our end of life programs. We have technology that looks at predictive algorithms for individuals that are at risk of mortality at 6 months and risk of mortality at 12 months. That helps us to outreach individuals and talk about things that often, people don't want to talk about, or they don't want to talk about with their family. And we have conversations with them about, what is your idea of a good death? What do you want? What do you want to say that's not said? Do you want to be involved in, are you interested in hospice? Are you interested in palliative care and things like that? Another predictive algorithm that we use is what I call a risk stratification. So I told you I'm taking care of population. So on any given day, I could be taking care of thousands and thousands of patients. And they're not all high risk. So we have a very robust risk stratification, and it's based on comprehensive assessments, social determinants of health, my ADT feeds, these feeds, alert management technology that come in and say, these people are at risk for ED visits based on past encounters or hospitalizations. And that goes through a predictive algorithm, and it tells my host of clinicians they're at low risk of hospitalization, they're at rising risk. And I say rising, it's not medium. Rising risk is without appropriate care delivery or care management, within 6 months, they will rise into the level of high risk. We have predictive models. I talked about depression. I have predictive models that I use for depression. Depression is one of the most underdiagnosed symptoms out there. There is actually strong evidence that shows, I think a study I read, a number of studies I read, that I think it was 80-year-old males. There was a significant percentage of them, that many of them committed suicide within like 2 weeks of seeing their primary care provider. We have a tendency to medicalize symptoms. So if we medicalize symptoms, we might treat the insomnia and the weight loss and the person that's not getting dressed in the morning as a functional ADL, a deficit or whatever. But together, that might be the complete clinical profile of somebody that is depressed. And so we use these algorithms to say in clinical decision support to us, have you thought about this? Have you thought about this? We also use it for risk of sepsis. Sepsis is one of the most significant reasons why people are hospitalized, and indeed mortality, very high risk of mortality. And we use, so we have a predictive algorithm that, based on certain data elements, they tell us this person's at risk of sepsis. So it allows us to do preemptive interventions ahead of time just to mitigate that risk. So we use a lot of predictive algorithms and, that kind of thing. And just today, I was talking to my research center. We have a research center. And I said, I want to go from prediction to prescriptive analytics now. Tell me when the next best action is. If I do this today and I do it for 3 months, what will be the outcome? And I have an interdisciplinary team. I have health coaches, nutritionists, pharmacists, nurses, nurse practitioners, therapists, all on my team. So I want to know like the right mix at the right time, at the right duration to activate certain assets. So, yep.
Awesome, thank you. I have another question from the chat. Any advice on how to advocate for policy change?
I would say for us, and me personally, and for the organization, all that is managed through our government affairs, but we do public testimony. Anytime there is a rule that comes out, some kind of public, it comes out with public comment, we always respond. I've served on 3 technical expert panels when they've actually asked for feedback, vote, have your voice heard. Many times these government, if they're changing anything in policy, they will have what's called public hearings, and we participate in those public hearings. So there was just a public hearing about the controversial about mental health individuals, and their about whether they would be forced to to take their medication and things like that. And our whole behavioral health team actually went and participated in that public testimony as at these hearings. So, and don't be afraid to enter into there's a lot of what I do at the association level, the American Heart Association, and even in the academy, we have a whole segment that's around health policy. And frankly, serving on boards, NOBC, Nurses on Boards Coalition, is another way that I have influenced health policy.
For our students who might be thinking of wanting to work in health policy, so like at VNS Health in government relations, what kind of preparation or graduate degree or volunteer experience with a bachelor's might help them?
Yeah, I think it's somebody's saying to me they worked at VNS and why. That's nice to know. So in our government affairs group, we have I think a couple of them actually have masters in government affairs, but some of there are MPHs, masters in public health. We have a disability advocate who actually is an individual who has a disability, and he's been very involved in like concepts for independence, disability, living an independent life with disabilities. I think it's a mixture. We have our organization actually in government affairs, they had 4 or 5 interns this year, even over the summer, that became immersed in what we do in health policy. So
one more in the chat. How do you reach vulnerable populations that are in the gaps of systems that generally oversee them? Example, not in Medicare, disability, food stamps, and so on. How can patients find what options are available to them? And how can you expand eligibility? 3 parts.
Okay, so it depends. Number one, so for example, we work with a lot of payers, Medicaid, manage a lot of managed care payers. So in a case with something about benefits that individuals aren't aware of, we actually advocate for them and tell them, do you realize you have a SNAP benefit or a transportation benefit or an OTC over-the-counter benefit? Many of them will have OTC benefits and things like that. For individuals that are looking to see if they're Medicaid eligible, we have a Medicaid eligibility unit, which actually assists individuals to navigate what I call, not just apply, navigate. We have a very complex system and to help navigate that. I will tell you, just recently, and when I talk about passion, I say things that I look at things that, okay, like what other creative thing can we do? And just recently, we engaged in a whole geo hotspotting initiative with my team that I led, and we looked at areas of certain communities, and we looked at the South Bronx, and we saw that there was a high level of poor health literacy in the South Bronx. So I said, okay, we are going to 2 of my educators, I told you, it's completely tied together. to my educators became certified in health literacy. So we always pride ourselves on having health literate materials, fifth or sixth grade education and everything, but this takes it a step further. We're actually developing stoplights that demedicalize medical terminology. We have health coaches that go with these individuals to their physicians' offices, because there's a phenomenon called white coat syndrome. And that white coat syndrome, patients or individuals will sit in a doctor's office and forget every question that they were, because they're so intimidated, forget what they were going to ask. Well, the health coach says, well, like, what about this? Or weren't you going to ask about that? Or weren't you going to? So they help them. And then there's also associations out there. So the Better Medicare Alliance is helpful that way. There are, different community-based organizations that will help with, there's even attorney firms and everything that actually will help with Medicaid applications and things like that. So it's, it really depends. It's on, in terms of determining what your benefits are. There's also, if you're becoming 65 and Medicare enrollment, you start getting bombarded with all that mail, and you say, how do you cipher through it? There's websites and hotlines and all kinds of things. But we pride ourselves on helping individuals navigate all that. To me, that's part of care navigation and care management as well. And there's certainly what I call community-based organizations out there that will also help you navigate, the sort of the confusion around, what's better, what's a better plan, those kinds of things, and what benefits am I eligible for.
I have another one that just came in through the chat, kind of related to the previous discussion about AI, but how is the progression of technology impacting patient care today?
I would say, on one side, our clinicians are all have what's called handheld tablets, and many of you can go into a private practice and you'll see a physician that's entering, information or whatever. And even at the bedside now, like if you've been in a hospital, they'll roll in the technology. You have to be good at being able to handle the technology and still what I call the interaction between the patient, the client, the member, and yourself. So you have to be able to sort of navigate both. I think the technology has helped us. I used to hear these urban legends that seniors don't have smartphones, they don't know how to use them, and they don't like them. Well, our seniors use smartphones. They're pretty smart, and they use our IVR. So I'll tell you a little story. We implemented our interactive voice response. And our interactive voice response is basically we have scripting. And I said during emergencies, we'll ask them if they have food in the house. Do you have your enough prescriptions to get you through a snowstorm? Do you have this? Do you have, are you feeling okay? Do you have somebody that can be with you during this? And it has a whole bunch of scripting. And when we rolled out that technology, we rolled it out a couple of years ago, people would say to us, oh, I don't think they're going to use that technology. They're seniors, they're not going to use it. And I said, well, let's see. And I said, the key is that they have to know that all they have to do is press a button and get a live person, because they need to know that this is not just like a telemarketing thing or whatever it is, a robocall or whatever it is. They need to know that if they truly need a question answered or that they're going to get a live person. So we rolled out this technology, and on the first day, and we had, all these statistics and percentages about how many calls we were going to get and what the staffing would be needed for that. So the first day, everybody pressed the button. Everybody pressed the button. And they're like, Rose, everybody's pressing the button. And I said, wait a minute. I said, I think they're checking that we have to establish a trust thing with them. They're testing us to see if they press the button. I said, this is part of the relationship and the engagement they have with them, with our, patients. And I said, they're checking to see if they got. So everyone pressed the button and they all got a live care manager, and they're like, okay, just checking. And, we've been using that technology for years now. And, when somebody is escalating, so like you ask somebody if they have enough food in the house, and they may have enough food in the house, but they may say, but I'm not feeling that great. They press the button, so it's not just that one thing, it's sort of, that's the lead-in gate, what I call the gateway question, and then it opens up to see whatever else is. The remote patient monitoring technology, they love it. It's a tablet. They think they get their own iPad. They play, there's education on it, and patient education. And if they answer certain questions, they get a happy face. Some of our, some people didn't love it. Some people wouldn't, they just love to be able to press the button and check, because we provide 24/7. Some of them just press the button to make sure that in the middle of the night, when they wake up in the middle of the night, and maybe they're having nighttime anxiety or something, they're lonely or whatever in the middle of the night, and they live alone or whatever, all they know is they have to press the button, and somebody from our contact center is going to say, what can I help you with? So I don't believe that seniors don't use smartphones.
I have a question. So you mentioned, Dr. Madden Baer, about caregiver burdens. At a public event recently, I heard a CEO of a major health system, I won't say which one, talk very proudly about reducing hospital stays even after major surgery, to day surgery, so that the person could be discharged and then taken care of with telehealth monitoring, so there would be the quality of care there. But the person didn't really mention the family caregiver burden shifting to somebody who doesn't necessarily have the training and skill or the time that takes. And do you think that is going to accelerate?
It's interesting you said that. I just read a study today that said they looked at, so there's a phenomenon that's called hospital at home now. And in hospital at home, they actually, for certain criteria of individuals, certain diagnoses, they actually will replicate the hospital experience at home. And so they have, twice a day nursing, a nurse practitioner will come in, some of the diagnostics, and they get an aide, and the aide is probably there for a number of hours. And they looked at caregiver burden between the person in the measured caregiver burden for the person in the hospital and caregiver burden for the person that had engaged in this hospital at home. And they actually found no increase in caregiver burden, which was interesting. It was surprising because everybody assumed. But I think the secret sauce, or like the magic bullet or whatever it is how much support you give them in the home while, when, during this hospital at home experience. And I think the aid is key, having the aid there. So, it's not bricks and mortar. They do have, round the clock. You can get, and the benchmark is that if something is happening, like somebody has to get to the home within like 2 hours, when the person comes home, so that the person's not left saying, okay, what do I do now? Somebody needs to be there by within 2 hours. But you know what, Marcus, I can send you that study that literally I read it today, literally about caregiver burden and hospital at home, because it's it's really become very popular. And today I'm doing, my NPs are doing retinal scans, bone density, PVD scan, peripheral vascular disease scans. We're doing imaging at home and all of that. So, you go into, anybody that's ever had a bone density, you walk in and there's this big, apparatus, and it looks like a big CAT scan and all of this. I have nurse practitioners that are using handheld devices to do bone density. And then we're using, retinal scans where ophthalmologists are reading it on the back end. So I thought that was surprising. I thought that, maybe it might be, it might be more, but maybe it's, a matter of seeing the person there and knowing, like, being right there versus, having to depend on other people to communicate how you care, how your loved one is doing. I'm sorry, I have a tickle in my throat all of a sudden.
I do see one question from Assistant Dean Sophie Kaufman. And how can we encourage more students to go into home care, especially nursing students? It's a great question.
It is, and one that I am very passionate about. So we have a nurse residency program that we take brand new graduate students and put them into a nurse residency program where they have all the supports they need, seasoned preceptors, seasoned, it's a 9-month program. They learn a day in the life of and all of that. I will tell you, 40 some odd years, maybe not 40 years ago, I was a nurse in undergraduate school, and I went in, I had my home care rotation, and I was in the basement of a church doing blood pressures. And then I asked my daughter's really good friend who went to a recent nursing school, and I said, what was your home care experience? She goes, I was in the basement of a church doing blood pressures. And I said to myself, oh my God, we do so much more than that. I mean, we have hospital at home, we do this, we do that. So we're, one of the things VNS Health has really sort of taken the charge, or the banner, is that, it doesn't, it's not what I call, like, low-level nursing, or it's not despecializing. We're doing all kinds of things, in terms of technology, in terms of, and there's autonomy, there's independence, but you do have the supports if you need it. So, and frankly, it's the future. Everything is pointing to home and community-based services, and everything you read is primary care is moving back home and all of that. So please, please, please consider a career in home care nursing. Thank you, Sophie.
Thank you so much, Dr. Madden Baer, for your time today and for sharing your wisdom with us. And thank you to all our students, faculty, and staff who took time to attend our roundtable, to Development Alumni Relations and our team in ALPS and Marketing Communications who helped to organize. And again, thank you very much.
Okay, thank you. Thank you for having me. And thank you, Marie, for, I remember congregate care very well. So thank you for sharing that. So, all right, thank you, everyone, and have a great evening.